Our next speaker, Dr. Andrei Schmidt, is a well-known name in the field of endovascular intervention. He's from Park Hotel, Leipzig, Department of Angiology, and he's the chief senior physician there. Welcome, Andrei.
Fine, yeah. Thank you very much for the introduction, and especially thanks to the organizers to bring me here. It's a big pleasure for me and the first time to be here. It's really great to be here. So I was asked here to give my first talk about, to give maybe an idea of the current status of femoropopliteal interventions. This here is my, does it run? Can you switch, continue, or? Yeah, my disclosure slide. So, of course, if you want to question this, to answer this question, you have to follow a lot of questions. Like, for example, you have to start with the question: where are the indications, clinical status, what is the lesion morphology which you want to treat by endovascular, techniques, technologies to pass the lesions, techniques to do the angioplasty itself, and of course also the post-interventional treatment and surveillance is important for our patients when we do an endovascular treatment here in this arterial level. In this talk, I will concentrate on the techniques, maybe technologies to pass occlusions or stenosis, mainly occlusions of the SFA, and also to answer some questions about what kind of angioplasty technology and technique we should maybe use. So to start with, this is, an ongoing question. If we have a total occlusion of the SFA, should we try it interluminally? Shall we go through subintimally? What is actually the best way to do it in terms of success and also in terms of patency later on? And so far, we do not have any randomized trials to compare these two different techniques to pass occlusions. And we're actually quite left alone with this question. However, there was a publication here now last year, which I found very interesting and very helpful in this regard. It is coming from Japan, where they tried to compare a group of SFA occlusions, long SFA occlusions, in an intraluminal way compared to a subintimal way. And it was retrospective, of course. This is a weakness, and however multi-center, and this was done by cardiologists. And you know very well that Japanese cardiology, if they try to go through a total occlusion intraluminally, they really try it for hours with many wires. So I think you can really believe this group of 651 patients where they tried interluminal with 014 wires compared to a subintimal way with an 035-inch wire. But what you can see here is that the results were pretty the same. Success rate the same, procedural complications also the same. Procedural time, however, was longer when you try to do this in an interluminal way. And the endpoint was here the 3-year primary patency after stenting, however, was also completely the same. And there was a switch over for 25% from the interluminal group to the subintimal because they failed to do this interluminal. So they concluded that actually you can right away take an 035-inch wire and do the subintimal way, and you will reach your goal much faster. What's not shown here on this slide is that actually in a subgroup they tried to figure out, are they really interluminally when they try to, or are they subintimally when they try to do this by IVUS or ultrasound from outside? And what they found that not always when they tried to do interluminally, and they thought they would be interluminally, they were by ultrasound, and also not always when they thought they were subintimal, they were subintimal, sometimes we were also intraluminal. So at the end, it's only in comparison of the intention to do this interluminally or subintimal, and it's not really a big difference which way you do this. And seeing these results, of course, this questions also the value of the recanalization technologies, the fancy new ones which we have on the market, like Frontrunner, Avenger, Wildcat, Cross-Catheter, TruePath, for example, whether they really have a value, whether it's really worth to spend the money to try interluminally, why not just go subintimally? Clearly, this also has problems. If we do this, we might have the problem that we cannot re-enter distal to the occlusion. In this situation, however, we have very nice re-entry devices for quite a long time already. The Pioneer catheter, the Outback catheter, now also the off-road system, and also the Entier system from Covidium, and they really help quite a lot. However, they are also quite expensive. And I also think they have other disadvantages. For example, if you have such a situation, reconstitution here at the adductor canal, very typical, big collateral, which might be important for the patient in the future. When you take a re-entry device, if you cannot re-enter here, right at the level of the collateral, you're never really sure where you are re-entering. Are you re-entering proximal to the collateral, at the level of the collateral, or maybe distal to that, some millimeters? And if you do this, the last two situations, you might balloon and stent over the collateral, and this might have an impact for the patient in the future. So therefore, what we think is not only in terms of money, because these devices are very expensive, the retrograde way is the more precise way, and you have a much higher chance to save collaterals because you're going directly into the occlusion here, proximal to the collateral when you go here retrogradely in. And we have the feeling there is quite a revival of going retrograde. The transpopliteal approach we know for a long time. It's very cumbersome and inconvenient to change the patient from supine to prone. So therefore, what we do is we always try to find a solution, leaving the patient supine and puncturing the artery more distal to the occlusion in a retrograde way without changing to the belly position. And this is, for example, our technique typically for a typical SFA occlusion, which goes down to the adductor canal. We puncture here a little bit higher than the patella here in the thigh in a supine position. When you take the needle here into the thigh, then the needle will reach here the artery a little bit distal to the occlusion. And then we do this, by angiography. We inject some contrast from above because we always have a sheath in here. And then we take our needle down here to the artery, a 9 centimeter 21 gauge Cook needle. It's usually, we also use oblique views if we have problems to puncture the artery. And usually we don't take a sheath in here, but just a support catheter. And then we go through the occlusion from retrograde or the last remaining portion here and snare the wire proximal, and then we continue from above. So we think this is a very helpful and very easy and elegant way to open up difficult occlusions. So now the question, when we have passed the occlusion, how do the treatment now? Shall we take plain balloon now? Shall we take cutting, scoring balloons, nitinol stents, covered stents, maybe atherectomy, drugeluting balloons, or maybe also drugeluting stents? The silver PTX currently the only one available. Well, to answer these questions, I think randomized trials are most important to do this. And for some technologies, we do have some, for example, for cutting balloons compared to conventional balloons, not very big trials, but some here for de novo lesions and for in-stent restenosis, the cutting balloon was tested, and there was completely no difference to a conventional balloon. So I think we can forget about using this on a broad basis. This is actually, however, also not a big surprise. Nitinol stents, non-coated nitinol stents, then have been proven in several randomized trials to be better than plain balloon angioplasty. We know this very well. So this clearly then was changing the method how to do angioplasty in SFA lesions. However, there is still quite a gap. It can be better here. Restenosis rates still seen here, something like 30% after 1 year. So you can be better. And the next step, which really changed quite a lot, was the introduction of the silver PTX drugeluting stent here by Cook. The 1 year results, you know. Here you can see already the 4 year results we have available from the randomized trial. You can see here that, or still after 4 years, the silver PTX stent is better than a non-coated stent. I would say the silver PTX somehow created a new benchmark, what we have to achieve in SFA lesions with our technology. What about others? The Viaband, the newer one here, the Viastar trial, randomized compared to nitinol stents. You can see here, maybe not so much in shorter lesions, but for longer lesions, there seems to be a benefit for covered stents compared to nitinol stents. So maybe in long lesions, this can be an option. What about atherectomy devices? We have atherectomy devices now for more than 10 years in our cath labs, the Silver or the Turbohawk, the laser, the CSI, now the Jetstream as well. Unfortunately, so far, we really do not have randomized trials showing us really are they really of value compared to maybe plain balloon or a Drugeluting balloon or whatever. We have registries, we have bigger registries now. The Definity LE study, for example, included 800 SFA lesions, which was treated by a turbohawk here. This is a comparison between the diabetic and non-diabetic patients in lesions with a mean lesion length of 74 millimeters. But what you can see here, also here somehow an 80% patency rate was achieved with this technology here after 1 year. I think the Drugeluting balloons clearly will change now our doing in the future very much. You all know that several trials were done here with different Drugeluting balloons. Every Drugeluting balloon clearly has to be tested by itself because everyone is a different device, mainly due to different carriers. And here you can see the first ones, the Thunder and the FEMPAC trial. Here the balloon from BART, the pacifier, the balloon from Medtronic, Biolux. So these trials here showed that the proof of concept, it works. The endpoint was late lumen loss after 6 months, and they were rather short lesions. So what we basically know so far from Drugeluting balloons in SFA lesions is for more simple lesions. We have now 2 bigger randomized trials, the pacifier with 1 and 2 year results and the Levant 1 and 2 trial, but also there more benign lesions were included. We don't know so much about more complex lesions, whether Drugeluting balloons might work there or not. However, we have gained some experience with Drugeluting balloons in longer SFA lesions. I would like to show you here one example which demonstrates how effective they are, and on the other hand also how much we still have to learn about Drugeluting balloons. Here you can see a really long lesion from the common femoral artery down to the P1, P2 segment, so clearly task D lesion, which should be treated by bypass surgery. We have done this here with the Drugeluting balloon. You can see here the result. And I'd like to ask you, would you leave it like this with all the dissections you can see here? It's maybe not only dissection, but recoil and residual stenosis. Only the proximal part here looks actually quite nice. So usually we would not think that this could stay open after treating with a Drugeluting balloon, but since we heard that others will also allow a lot of dissections to remain as they are without implantation of stents, we tried to leave it like this. And here you can see the result here after 4 months. The patient was nearly symptom-free, and you can see how nicely these dissections healed out here in this former very much dissected area here. And that was really quite a big surprise. The patient came back after 2 years with some new onset of claudication on the left leg. And this here is after 25 months angiography. And this was, again, a very big surprise for us. So because all this area here, which was treated with Drugeluting balloon, was really quite nicely open, there was only very short focal restenosis. And this is, I think, what we also have learned from below the knee, that if restenosis comes back after DEB, it might be much, much shorter than previously, and not that diffuse restenosis, which we see, for example, if we implant non-coated stents in long SFA occlusion. And this, of course, makes retreatment much, much easier. But I think the most interesting fact here in this case is, and this demonstrates how much we still have to learn here using Drugeluting balloons in the SFAs, that this is, again, a comparison of the result after using Drugeluting balloons and after 25 months, that this area where we actually thought we don't need a stent, but the was restenosed, but the area where we thought we would definitely need a stent was completely nice. So many open questions for the future. Nevertheless, I think we can already say that also with our results, which we have achieved in our center, treating here 288 femoropopliteal lesions, quite long lesions here with the Drugeluting balloon, a patency rate here was achieved of nearly 80%. We can say that Drugeluting balloons will help us and change also the mode of treatment of long SFA lesions, probably highly likely in the future. Of course, not all lesions are the same. They are sometimes very, very calcified, and clearly this doesn't make sense here to treat this with drug-eluting balloons. I probably all agree. I don't think it also makes sense to use here an atherectomy device. And it probably also doesn't make sense to use a regular stent, because you can see very frequently that regular stents will be squeezed and will look like a sheath of paper here, very flat. And we have also seen in a registry that if you leave a residual stenosis after treating this kind of lesions with a regular stent, the restenosis rate also is higher, maybe because of this non-opened stent. So these kind of lesions clearly are those where we implant a high radial force stent, and this is the one which we use for very calcified lesions, the Superest stent, which is now acquired by Abbott, which shows 4 times higher crash resistive forces, or radial force, if you want to say it this way around. And here, this lesion, once again, very calcified SFA occlusion, where we, of course, went through subintimal, no way to try this interluminally, and especially if you see after balloon angioplasty to have such a residual stenosis and recoil, we definitely go for the implantation of the Superest stent, which is completely different to any other nitinol stent and has a longer learning curve, clearly, to use it, especially in calcified lesions. But once you have it in, you can be sure that it will not be squeezed and compressed from outside by the calcium. It will be round and nicely open, and by this you might achieve better results, especially in very calcified lesions. This is our registry from Leipzig, 107 patients treated with the Superest stent. You can see here, even after 2 years, a primary patency rate of 76% is really quite good. And so far, we have never observed any stent fracture with, in this stent. So how to know now what should we actually use in SFA lesions with all these data. Once again, back the silver PTX stent, as I said, created some kind of new benchmark which we have to achieve with newer devices if we want to compete with this stent. Superest stent so far seems to be as good as the silver PTX stent. However, we don't have any randomized data so far, which I think we need to really answer this question. Now also the newer Viabans also meet this somehow 70 to 80% patency rate in SF lesions, also for longer lesions. Even newer nitinol stents are now on that line, like the Misago stent from the Terumo, shorter lesions, but a little bit over 80% after 1 year. Also our drug-eluting balloon is not bad, with 77% after 1 year in longer lesions, and even the atherectomy device, the TurboHawk, with something like 70-something% after 1 year is also not bad. So really, how to decide now which treatment should be used currently in SFA lesions? It's really not difficult, and I think we have to decide from one lesion to the other. I only can show you what we are currently doing in our lab. If we have an SFA lesion which is not too calcified, we predilate. If we have a severe dissection, for example, we go directly for the implantation of a drug-eluting silver PTX stent. If we have good results after predilation, we go for a drug-eluting balloon. If we then have residual stenosis or dissection, we add a bare metal stent on top of this. But if we have a very calcified lesion, then we directly go for a high radial force stent like the Superest stent. Thank you very much.